Morning, everybody. Came in a bit late, so I don't know exactly the mix of backgrounds in the room. Any clinicians in the room? Great. Tech folks? Wow. And everyone else. Okay. All right. Well, what I'm going to do, I'll stay here, and I'm a bit jet lagged, so I'm going to refer to my notes a lot more than I usually do. But what I'm going to do today is really describe a vision for a future state of care delivery where that state is simply not possible without the use of data, without the use of tech, without the use of devices in all the places where we live, work, and play, gathering information and helping identify, predict risk, and helping nudge us into the right behaviors and so on. So that's the vision that I'll describe, and I'll then highlight a few areas where that vision is actually being brought to life on a pretty grand scale, right? So that's where I'm headed. It's a really incredible time for the industry, as we all know. Lots of opportunity and increasing pace of innovation, changing expectations, and also incredible uncertainty, especially around how care is paid for, who receives care, etc. And regardless of our preferences, opinions, personal politics, few facts are clear: that healthcare costs are way out of control. Employers, payers, and governments continue to look for ways to address them more forcefully. And consumers are becoming more involved, engaged in our own care, all within the context of populations living longer, people living longer, with increasing challenges associated with aging, right? So that's the world we're all living in now. Big mess. Lots of opportunity, lots of challenges. It's a dynamic time as our governments, our care institutions are all trying to transform to address these challenges. So I've had a ringside seat to watching this from both the US perspective, and I spent quite a bit of time in the UK, across the EU. I've got experience in places like Singapore and Australia as well, that comes to bear on what I'm about to share. And really, just I'm here to share some of the lessons I've learned along the way. I hope you'll find it useful. So, next slide, please. So over the past decade in the US, likewise in the UK and other countries, we witnessed a sustained commitment to help move care into the digital age. So there's been a lot of spend, massive investments by governments, payers, providers that have helped move us beyond paper charts to widespread deployment of electronic health records. We read about this stuff every day, or very frequently it seems like. And even organizations with very limited resources have taken the plunge, sometimes losing their CEOs, losing their CIOs along the way as they've implemented these big systems. Can anyone guess what these figures represent? These are very big numbers, and these are the types of budgets for implementation of electronic health records at, reasonably sized, not the biggest, reasonably sized health systems across the US. I mean, these are very big numbers. Next slide, please. Actually, I have a clicker, so thank you. So when Congress passed the $840 billion stimulus package underneath what's now called Obamacare, it allotted funds for hospitals and medical providers to digitize their records via what was known as the High-Tech Act. Spent $35 billion to fund electronic health records and related systems, right? And when viewed very narrowly, in terms of bringing digital records to life across the country, this obviously succeeded because most hospitals out there now have electronic health records. Most hospitals have moved away from rooms full of paper charts into the digital age. Many of you have possibly lived through the implementations of these EHRs and their demands, and for many, the frustrations and costs of reporting under meaningful use, which, by the way, 2 days ago got renamed, right, and got recast as not a program for meaningful use of electronic health records, but as a program for interoperability, right? Just getting data flowing out of these systems that's locked up in these systems. So the challenges with getting longitudinal information about your patients via health information exchange and registries that identify patients at risk, and tools that sometimes, with tremendous demands on your time, measure the quality and cost of the care you provide, those are the big challenges. So this is great that, across many of our economies, we're seeing this progress. But there are also common themes in terms of challenges, and this is global, so we shouldn't feel alone here. Despite the differences in how health is financed, despite similar investments in all these economies on digitization, we're finding everywhere the same stuff. Now, everyone's complaining about healthcare cost. There isn't enough transparency, both from the patient side and from the care provider side, especially around cost and outcomes. And not a week goes by without some news story about someone's horrible experience while they or their loved one received care. We're also starting to hear more and more about increasing disparities in access to care. And clinicians in particular, everywhere, this is universal again, are getting increasingly frustrated by administrative burdens, badly designed technology, and the cost pressure, and this is key again, cost pressure to do more with less, right? The gravy train, when you look at the NHS, the National Health Service in the UK, for example, the notion that a hospital could be in the red year after year after year, and at the end of the year, when the next budget season came along, well, they'd get funded anyway. Somebody would come and close that budget gap, and off they went again. Those days are over, right? And that's exactly what I'm hearing from CEOs across the US as well, that the biggest pressure on the CEO's mind in the typical health system, especially safety net hospitals, community hospitals in the US, is just how to break even anymore. Cost pressures are huge. Right? And as alluded in the previous slide, the challenges in this journey have been significant. So let me just touch upon a few, starting with interoperability. So according to a government report released last August, only 56% of hospitals had received electronic records from someplace else into their systems. And only 40% of those, which is a tiny number, had actually managed to put that data into their own records. There's a study that Accenture just published in January about patient use of such data. And those numbers are even worse, right? So a full 56% of our population, whether we have access to our records or not, have never even gone online and bothered to do anything with them, right? Because we don't find much value yet, or it's too cumbersome, or there's time and expense involved. So this is all complicated by the fact that in many economies, even after all this data has been digitized, most of this stuff, about 80% or more of this data, is actually unstructured, right? So even being able to extract value out of this is a problem. Then we've probably all heard of this phrase called information blocking. Now, it's no secret that even when the technology exists to exchange information, business considerations of both the provider organizations, the hospital not wanting to share their data with another competitor down the street, and of course their technology suppliers. For most technology suppliers, this is a zero-sum game. Once they've sold a laboratory system into a hospital, they want to sell the pharmacy system, the imaging system. Eventually they want to sell the electronic health record. And it's not in their interest to make it easy for these institutions to use the best of whatever they want to buy, right? It's much better for these institutions. And it's a zero-sum game because everyone's got one of these already. So the only way that these companies grow is by displacing somebody else. And that's been just all your data's in one place. It's a lot easier, it's a lot cheaper, is what drives that, right? And then there's usability, which we hear about tremendously. So a recent study by the AMA, American Medical Association, found that 43% of physicians thought that their software actually made their jobs more difficult, right? So that's a huge number again, and this is pretty horrible. So this panel, this session is about data and how data can help patients in receiving better care. But what we're seeing is that data itself, being able to collect it and being able to aggregate and being able to put it to use, that we've got foundational problems before we even get to the use of that data, right? An example of a consequence of medical records being hard to use. Hospitals are hiring up medical scribes now, right? So what's that mean? And imagine what that means. There was this huge safety benefit touted of electronic health records, where as you were delivering care to a patient, if you were using electronic health record, you were prescribing something, you'd find out immediately as you were prescribing that something was contraindicated, that there was some reason why you should prescribe something else. Or from a cost perspective, that the medication you're about to prescribe, well, there's a therapeutic equivalent that's cheaper or that's on formulary. Right? Those kinds of things are real-time feedback that physicians are supposed to get. Well, if they're not using this stuff, they've got scribes using it, that decision support, all the investment in that decision support becomes just worthless. It might as well not exist, right? So significant challenges there. And then financial savings. This is kind of the kicker, right? The big problem that most health system CEOs are facing is how to keep the lights on. And then when you look at the financial savings that this stuff was supposed to produce, well, when the HITECH Act was originally conceived, which, by the way, if I sound negative about it, I'm not, achieved a lot, but there were some misfires, and this is one of them. It was expected to save Medicaid and Medicare about $12.5 billion through 2019. Right? None of that's happened. Like almost no savings have been materialized out of this. Productivity, you can imagine, and patient engagement, you can also imagine that there's been very little of this benefit accrued. Okay, so that's the data story about just being able to collect the data. Then you actually step back and you say, well, where's the cost? And I see some people squinting. I'm sorry, the white is hard to read. Where's the real cost in healthcare? The real cost is actually in chronic conditions, right? So we're spending a huge amount of money digitizing medical records. Needs to happen, but the 60 to 70, and depending on the economy you're dealing with, the 78% cost problem in the economy is really chronic conditions and their comorbidities and what it takes to manage them. And management is where we're at today rather than prevention or mitigation or improvement, right? We're in management. You imagine diabetes, it's a boil the frog problem. Somebody, you wind up from one level of acuity to a higher level of acuity without realizing that you're actually going down that journey. You one day wake up and you're actually a lot more sick than you were. And what you wind up with along the way is just adjusting to the change in the increasing deterioration in your health status. From a management perspective, it's the exact inverse, which is you're going from a lower dose of a lower strength drug to a stronger dose of a higher intensity drug, and so on until, well, you die, right? I mean, that's the progression. And the progression is really all about how do you identify people late and then deal with the consequences until the bad outcome happens anyway with a lot of cost. And that's what chronic conditions cause. And so just looking at the US population, nearly half of us, 45%, suffer from at least one chronic disease. More than 2/3 of all deaths are caused by one or more of 5 chronic conditions, which are heart disease, cancer, stroke, COPD, and diabetes. And more than 1 in 4 Americans have more than one chronic condition, right? So this is where the big tsunami of cost is, and the big tsunami of just a poor health status is going to come from. In the UK, they've already figured out that diabetes is going to bankrupt the National Health Service by 2020. It's now already, that's what they talk about, that the cost of just that one condition, the management of it, is going to bankrupt the NHS. And yet, there's only been £10 million allocated so far towards patient education programs or consumer population education programs around healthy lifestyles and diet and other habits to even walk towards the prevention. Okay, so then when we look at, again, following the money, as populations age, more and more people are characterized as high risk for multiple chronic conditions. The thing that we also now recognize, and this is new in the industry, is that an individual's choices have an impact, including where we live, attend school, work. So there's a phrase being used now, the social determinants of health. Well, there's no secret here. We've all known this for a long, long time, that our social environments, our social relationships, the support structures that we have around ourselves, the level of safety in the places where we live, all of those things have tremendous impact on our health as well, especially as we age. We're finally starting to recognize that as well. And while most people don't ignore, your car's check engine light, most routinely skip our own body's preventive maintenance warnings, right? So all this information we have individually about ourselves, but it's not brought to our the forefront of our experience because it's not been made apparent or obvious. And so we choose to ignore it. Or even when it's made apparent or obvious, well, we'll deal with it later because it's our health. The result is really poor collective health quality in a country that spends more on healthcare than anywhere else in the world, right? So that's the context, and this is some of the consequence. 78% of our total spend is on long-term conditions. That includes cancer as well. 96 cents per dollar spent on Medicare goes on long-term conditions. 83 cents per dollar spent on Medicaid goes to just the care and feeding of long-term conditions. And those are kind of crazy numbers, right? And these are big budgets, okay? How am I doing on time? All right, okay. So where do we go with this? And so new model of care that begins to address these challenges head on, again, back to the data story, begins to address these by causing some fundamental shifts. Number one, a shift in location. So we think of care as ultimately when we need help, we wind up in the emergency room or we wind up in the hospital, and that's where we get care. More care needs to shift from these very expensive locations into more convenient, less expensive community-based settings, everything from retail to home. And some of the moves you've seen from CVS, from Walmart, from Walgreens, over the next few months, we're going to see some of this happen. That's some of the thinking behind some of these moves, just a shift in location. But a lot more has to happen, especially around acute care. Well, we've now seen proof that you can safely take care of patients with heart failure, with cellulitis, with COPD, with pneumonia in their homes with a hospital-at-home model, which has now been proven to be about 30% cheaper in 6 studies that have been conducted than the equivalent admission in a hospital. Well, what's that mean? That shift in location is what is going to drive quite a bit of a recalibration of our economy. Second, the care team itself, right? So we've defined the care team as the doctor in the hospital or the doctor in the doctor's office and the folks around them. But really, the care team is about also community-based professionals, everyone from your retail pharmacist to care coordinators to nurses, social workers, paramedics, along with friends and family. And then the silos that all this care is delivered in today. We need to coordinate care across these settings rather than just within the four walls of our own organizations. Our care plans are not unified across these settings, so that needs to change. And then, back to an earlier point, we need to move towards a model of prevention rather than management, and a focus on money, where we're spending it, and actually addressing those issues rather than recalibrating where we're spending our money to address what costs the most rather than the flavor of the day. And then shared accountability, which is not just individual doctors in the moment of a visit, but doctors across the care team, shared accountability across the care team, including with the patient. And of course, we talk about experience as well. So none of this, it should be obvious that none of this is possible without data, right? And so what is needed to pull this off? Well, we need, firstly, longitudinal health records. And our entire attempt at pulling those off over the past decade failed, right? We tried to build these health information exchanges. Ultimately, those health information exchanges became just about messaging and pushing data when someone asked for it. There was no predictive, preventive capability there. And until we do that, until we as ordinary citizens, as people who are interested in our own care, have access to our own record and can make it available to wherever we want that available, so that that can be used intelligently to help us. Until that happens, this is going to remain a fundamental problem. And there are some great moves happening there. Next, patient-side diagnostics, right? So imagine if you could walk into a CVS or Walgreens and get your blood test done right then and there, with the results available right then and there, rather than having to go to a doctor's office or urgent care or someplace else with a big vial of blood drawn that's sent out someplace with the results coming back 2-3 days later. So that's 2 visits, time out of your day, which you don't have. It's a huge issue for people to even go get the test done in the first place. And then the results become available immediately so that your care team member there, whether it's a nurse, whether it's your PCP, can actually make decisions about your care plan right then while you're there, rather than having to come back or re-engage with what your record really was about when the results come back, right? So that kind of, the efficiency gains by themselves fundamentally pay for this. Then telemetry and environmental monitoring. So using data to get valuable context as we go about our days, as we go about our lives. Patches that monitor cardiac signals. The same hospital-at-home program that I described would not have been possible a few years ago because the technology to monitor you didn't exist. But today, there are about 20 companies with wearable devices that transmit EKGs in real time, right? So we're now able to engage in fundamentally new models that weren't possible. All of this tied together through predictive analytics and cognitive computing to make this data come alive and put it in the hands of our care providers, right? So that's where care needs to go. And I know we're running short on time, so what I'll do is pause and just open up for questions. Yeah.
Does anyone have a question? Oh, I'm sorry, sir.
What do you think is the first step in getting those records that are cross-platform and cross-need from like diagnostic stuff to general lifestyle information? What do you think is the first step? Do you think it's governmental? Do you think it's open source? What do you think is the first step we need to take in order to move that direction?
Okay, so been involved with interoperability since the mid-90s, before I even knew what that word was, right? My first system that I built in 1994 was a system to join up data across every system inside a single hospital. And nobody told me it was impossible, and we got it done. 25 years later, it's still considered impossible. I think the first step in getting that data freed up has nothing to do with standards. There are plenty of those. Has nothing to do with data quality. That'll solve itself. It has to do with the will of the institutions holding the data to release it. And the only way that that gets released is if we as patients demand that we need access to our own stuff the way we have access to our own banking records. Right? If we got that accomplished, if that data got freed up to be in our control, not ownership, that's not what I'm advocating for. You know, let the hospital that spent the $4 billion on that Epic system continue to own the data. But if I, as a patient in that hospital, have access to that in an electronic form, where I can then, through consent, open it up to any other app, any other system, that's what's going to solve this problem. And we've already solved that in the financial industry. You know, applications like Mint now exist that sit on top of, and they can suck in your financial records across every credit card, every bank, every lender, everything, and actually proactively start advising you, and hey, you just spent too much money on blah, right? And or did you notice that this transaction happened? Or you're paying too much interest, right? That kind of capability is bizarrely unavailable in healthcare, and it would just change the path of cost. And it would make us all so much more engaged in being able to manage our own care, right? So that's the first step. And I don't think government mandates are going to do that. I think what's going to happen is exactly what's happening, which is, you know, wearing my Accenture hat, we are seeing the top tech companies, everyone from Microsoft to Apple to Google, Amazon, essentially just not care and go solve the problem.